Anyway, half hour, so I got to talk about dizziness. I'm going to take a wild guess that it isn't your favorite patient. The patient is weak and dizzy. I'm just going to guess. Okay, so I'm going to actually steal a little of this talk from my friend Marty Samuels. Marty Samuels is I think he still is, the chief of neurology at Harvard. And he used to give this talk on dizziness at ACEP every year for many, many years. And while conceptually I wasn't happy about the idea of having a non-emergency doctor be at our conference, be the expert, this was the one exception. Marty was brilliant, funny, approachable, and taught things in a way that were relevant to us. They weren't about a specialist. Now, I see you nodding your head. Did you ever go to his talk? Yeah. Anybody else ever see his talks? They're fabulous. Just really, really smart. So he taught me a lot about this topic, I think. So I'm going to sort of paraphrase some of what he said. We'll go over the articles in the manual, which are consistent with that. Before I get to the articles in the manual, I want to talk a little bit about dizziness. So Marty always would say, what's the most important question, the single most important question you have to ask when a patient says dizzy? There's one question that changes everything. Does it happen at rest? No. How long? No. What? What do you mean by dizzy? That's the question. Now, he'd always warn you that there are 4 possible meanings of dizzy, and he would always warn us not to tell people what we mean, because once you put it in their mind, it gets tough. So you have to at least try to get them to say what they mean by dizziness. And there are 4 things that they could actually mean by dizzy. Now, how many of you have been dizzy? Every one of you, right? Come on, who hasn't had a beer? Come on. So what do we mean by dizzy? What do people mean by dizzy? Try to think of it yourself. I mean, we've all been dizzy, and I've sometimes thought, what does that mean? You know, it's like, well, it sort of feels funny, right? I mean, it's not quite like I'm going to fall over, but it just feels, at least my head is sort of weird, right? Well, that's not the only thing dizzy can mean. So let's go back to 4 things it could mean. What can it mean? What?
Vertigo.
Vertigo, great. So what is vertigo? Vertigo is the sensation of movement. Has any of you had vertigo? I bet there are a few people in this room who have had a vertigo, where the world is spinning around. You're looking, and the world is spinning very, very rapidly, and that's because you're having nystagmus. And nystagmus, your eye keeps jumping. It looks like, one of those old video scopes. That's a sensation of movement. Sometimes it seems like I'm moving, but mostly it seems like the world's moving. But they're the same thing. It's a sensation of movement, and it's related to nystagmus. What else can you mean by dizzy? Go ahead. Lightheaded. Lightheaded is sort of, I feel like I'm going to pass out. And lightheaded, we have a whole talk on syncope. Near syncope and syncope are the same thing. And basically, we know how to deal with that, right? Near syncope and syncope have some really bad causes that we're going to talk about, and they have a lot of benign causes. And we know how to work up syncope, and we're going to talk all about that later. Vertigo, same thing. There's central causes that are dangerous, and peripheral causes that are mostly not dangerous, although there's a couple of exceptions. And we'll talk about that. That's what we're going to talk about for most of this chapter. And our job is to figure out which are the ones we can't miss. So that's 2. What are the other 2?
Off-balance disequilibrium.
Disequilibrium, that's the really important one, because that is, I feel like I don't know where I am in space, and I might fall over. And it's often, I feel like I'm falling to the right. It may interfere with my gait. It may just be the sensation of I really can't do it. I may have a wide-based gait. Really important. That's almost always something you got to figure out today. That's something important. And the 4th one, it's a trick question. The 4th one is none of the above. Because none of the above is probably the most common cause. It's that sense that you and I have when you have the flu or something like that, where it's sort of like my head is funny. It just sort of, what do you mean by, I'm sort of dizzy.
Yeah, and culturally,
And there may be very big cultural factors.
Latinos use dizzy to say I don't feel well.
Right, so there are many different things that we can, that people mean by it. And when I say none of the above, I gotta add one caveat. It could also mean all of the above. You've all seen a lot of those patients where they won't tell you, it just sort of, it feels dizzy, and you say, so like, do you feel like the room spinning? And they go like, room spinning? Yeah. You go, how about, do you feel like you're gonna fall over? Yeah, I feel like I'm gonna fall over. And are you gonna pass out? Oh yeah, I'm gonna pass out. So if it's all of the above, if it's not clearly one of those things, that's the fourth category. And the fourth category is really important to know about because it turns out it's very common, and it turns out it's never important. That's not to say it isn't important to the patient. It may be really important to the patient, but it's not life-threatening. So if they can't say, no, it's that one, then the good news is your workup's pretty much over. There was a really nice article on this thing called the geriatric dizziness syndrome in the Annals of Internal Medicine 25 years ago. Big article which said, you know, this is very common in old people, the sense of non-specific, quote, dizzy, and we followed up and we did all sorts of millions of tests and none of them had anything. They all ended up, wasn't hematologic, it wasn't cardiovascular, it wasn't neurologic, we don't know what it was. And like most symptoms, it goes away. A really important article in Annals of Internal Medicine last year about symptoms, which made the point that most symptoms, we never figure out what caused them, and they get better. And that's the ones where people go to the doctor. Most symptoms, no one ever goes to a doctor, right? Because it just gets better. How many of you have had abdominal pain? How many of you have gone to the emergency room for abdominal pain? I mean, you know, once in a while. Well, you're sort of a wimp, that's why, but... No, I mean, you know, we all have symptoms all the time, right? You have a little pain somewhere and you just sort of ignore it. And do we ever figure out what that was? Of course not. But even when people go to the doctor, most symptoms, even symptoms that last a couple of weeks, you know, the best we can do is when we give it a diagnosis, it's usually a made-up diagnosis, which means I don't know what it is. So, in any case, getting back to dizziness, this is the key question, is to figure out which of those they mean. If it's all of them or none of them, don't worry about it. If it's near syncope, we know what to do with that. If it's imbalance, that's really important, and then that usually requires a neurologic workup. True imbalance, I'm falling over. And if it's dizzy, vertigo, sensation of movement, that's our job, is to figure out which of those are the few needles in the big haystack of benign stuff. So of vertigo, which is the rest of this chapter, what are the common causes? Bppv, okay, benign persistent paroxysmal vertigo. How do you diagnose that? Okay, you can do a Dix-Hallpike maneuver. Great, you can do that. And the textbooks will tell you that it's very sensitive. It picks it up when it's there. I don't believe that. I've done a million of patients who I'm pretty sure are positive, where I can't see the nystagmus. I do the Dix-Hallpike. Now you got to be careful. You got to do it both sides, in the center, both sides. You lay them down. You got to have a latent period after you've done it, where you wait 10 seconds, and then they go, oh yeah. But even with that, I often find it that they'll say, oh yeah, they'll cry out because it does exacerbate the sensation when you move them. But you look, you don't see the nystagmus. I don't know if any of you had the same experience, but I think it's pretty common. So the Dix-Hallpike, if it's positive, you're done. But I don't think that's really the key. To me, the key is this is a clinical diagnosis. What are the hallmarks of benign positional vertigo? There's a couple articles in here which say this. It's positional. When you move your head, it gets worse. Absolutely. Tremendously important. What else? It's episodic. What else? They get really nauseated. What else? It often happens when they wake up and they move their head first thing in the morning and oh my God. What else? It's fatigable. You keep doing the same movement, it gets not so bad. And the most important is it only lasts seconds. It doesn't last for an hour. You do it and they're violently dizzy for a few seconds, 10 seconds, 15 seconds at the most, and then it comes down. And you've all seen that when you do that Dix-Hallpike, even if you don't see the nystagmus, they get terrible and then it comes down. So this is a clinical diagnosis, and it's due to, a little bit of calcium breaks off and goes into the wrong place in the inner ear, and the way you fix it is by moving the calculus out. And that's called the Epley Maneuver, and the last few articles say, it works. And what's more, patients can be taught it, and it works. They can do it themselves, and they can fix themselves. And you can either try to remember what's in that, how many seconds you turn in each position and how you do it. I don't do that. I don't try to remember it. I have a little sheet which tells me when I have to have it, I pull out the sheet. I have this sort of worldview which says things I do all the time, I don't have to study to remember because I do them all the time, so I remember them. And things I never do, it's silly to study because I will forget. How many thousands of times have I studied the compartments in the wrist until I finally gave up? Because if you don't do it, you don't remember it, right? So I don't ever believe in studying details. I think we have to study big pictures, ideas, and then know where to look. And nowadays with the internet, you can look up anything as long as you know what you're looking for. So you don't have to remember the Hallpike, how to do a Hallpike maneuver, although that's so common that I think most of us know how to do it. But an Epley maneuver, just have a little printout which tells you how to do it, which you can give to a patient and tells them how to do it. And there's different versions of the Epley. But it's really, really important. It's sudden onset, often waking up, one position movement, really bad, lasts only seconds, fatigable. That's it. There's an article in the back, and I apologize, I don't remember which article says which, and I'm not going to go through them one at a time where I'll be able to tell you which is which, but it's easy to find, which says that drugs don't work for that. What you need to do for Bppv or Bppv is get the piece of calcium in the right place. And drugs just make people sleepy. There's another common peripheral cause which has 100 different names, but which is basically either viral or idiopathic, 2-day, 3-4 day lasting thing where somebody is actually vertiginous, not as violently, but it persists for hours to days. And one of them calls it acute peripheral vestibuloneuropathy. Sometimes it's called labyrinthitis. It's got all these different names, but that basically, there is no piece of calculus, you can't get rid of it, so you just give them drugs. And the drugs don't work because they work for vertigo, they work because they make people sleepy. Same way that muscle relaxants don't actually relax muscles. They just make you sleepy so you don't mind that much. Okay, so the big one is Bppv, that's at least half of the peripheral vertigos. And the others, there are some important ones, things like Meniere's syndrome and schwannomas, but they're not emergencies. They're not emergent. And then there's the common sort of viral or idiopathic thing that lasts a couple of days. So the next question, the first question is it Bppv? The second question, is it peripheral or is it central? What's the central vertigo that we got to worry about? Cerebellar stroke in particular. Almost all the things you have to worry about are cerebellar stroke, which is either bland or hemorrhage. The good news is, here's the really important good news. The good news is that the place back there in your cerebellum is a tiny, tiny crowded space. So it's almost impossible to pick off one little tiny area and not get enough of a problem that you have an abnormal neurologic exam. It's virtually impossible. Which tells us that if you want to know, is this something terrible going on back there, all you have to do is a neurologic exam, because if the neurologic exam is normal, you're done. Now, I got to tell you that some people violently disagree with what I just said. And the basis for this, as far as I can tell, was originally an article by a guy named Nystagmus in the 80s from Sweden, which said, we found a half dozen people who were completely normal, elderly, normal exam, and all they had was vertigo, and it turned out they had a cerebellar stroke, and beware. And it's very common, and you have to worry about it. Your manual has 10 articles which said we looked at registries of 2 billion stroke patients. None of them met that profile, 0. just presented with vertigo and had a normal exam. None, zero, not one. And there's a whole series of articles in there that say that. So you can believe Nyquist if you want, or you can believe the huge experience of everybody else, which is that it doesn't exist. And that what you really have to do is a neurologic exam. A couple of articles, including number 2, say when we miss it, when we go back to the charts and we say, you know, somebody was sent home with dizzy and they ended up with a stroke, we go back and see why did they miss it. Either there was an abnormal neurologic exam or the neurologic exam wasn't recorded. So you can believe that they did it and it was normal and we're all screwed, or they probably didn't do a good neuro exam. So another bit of philosophy here. I'm a big believer that in the emergency department, we don't do a complete exam. That we shouldn't do a complete exam. That when we're teasing about doing the show for mom, it's a great joke and it's really fun, but God forbid if we actually did a complete exam, because you're going to find all sorts of stuff you don't know what it means and you're going to cause trouble. Our job is not to go looking for trouble. Our job is to do a directed exam for what we're looking at. So every time we do blood pressure on a child who has a sprained ankle, we're being stupid. Why is that part of the emergency department? Everybody gets serial vital signs. Does he have a fever? Maybe that explains why his ankle hurts. So, I mean, I don't, you know, but fortunately we don't do that in everything. We just do it in things that are mostly benign, like vital signs. You got a pulse ox for a sprained ankle. Excuse me, I don't think so. But anyway, and you know, we'll talk over and over again why it's bad to go looking for things that that don't mean anything. So we do a directed exam, which means you shouldn't be doing a neurologic exam on most of your patients. But somebody who comes in with dizziness, you have to do a neurologic exam. You have to do a great neurologic exam. Now, I remember when I was a medical student that a neurologic exam was, you know, a little bit of magic, right? There were these guys, there were these wizards who had these incredible tools. They had these hammers that could sing and could play music and could read fortunes. And you know, they did, you remember those hammers, magic hammers, they did song and dance. We don't have to do that. We have to do a really good neurologic exam should take a minute, maybe 2. The critical part that we miss all the time, what's a good neurologic exam? There's a few parts, you all know this, right? So it's a mental status exam. Mostly the mental status exam, particularly in something like this, all you need in the mental status exam is do they talk and walk? Do they talk? Do they make sense? Do they respond to me? You don't have to do a mental state exam. Is the person being reasonable, or are they altered? 2, you have to do motor. It's really good to do a general motor exam. We're not looking for details. I don't care whether it's 2+ or 2-. I care, is it normal? Is there a focal weakness? Sensory, almost irrelevant, right? When was the last time you did a sensory exam that actually helped you? It's pretty much irrelevant. Sometimes it has some value, but mostly not. Reflexes, completely irrelevant. Don't ever do a reflex exam. It's useless. I lied. There are 2 places you should do a reflex exam. You should do a reflex exam if you're looking for cord disease. It's useful. And you do a reflex exam if you're looking for hypomagnesemia or hypocalcemia. Other than that, it's useless. So it's useless in dizziness. It doesn't tell us anything we want to know, and it's almost uninterpretable anyway. Remember we talked about reliability? Depends upon who's doing the exam and how we interpret anyway. So it's not useful. So forget those. So we're still with mental status, motor, and now we get to the big ones. Cranial nerves. You have to do a good cranial nerve exam. That's what's back there in this tight space. That's what will be abnormal. I'm not going to go through all the cranial nerves. You need to know them. I don't really care whether you know which one was which. You just need to know to test them all so that when it's abnormal, you'll say, oh, that's not right. And then, finally, the one that is always left out is the cerebellar exam. A cerebellar exam is your position in space. And so we all know to do finger, nose, and we know heel to shin, but you also got to do gait. Well, what if the patient's too dizzy to walk? That's okay. First of all, most of them are not too dizzy to walk. You can get them up and they'll do it. Okay? And when they really cannot walk, it's usually dangerous. But the good news is you can do a version of that, which is you just sit them up. And you're looking for truncal ataxia. And truncal ataxia is they cannot maintain their position in space. So when they're leaning back, they're fine, but you sit them up and they start going like this, like a drunk. That's really important. We should do that. That's critical. You do all those and they're dead normal, and this is not a central cause. Now there's one other clue here that there's 3 or 4 articles in this chapter on one other part of the neurologic exam that we should be really good at as emergency docs, that we should do almost never, but in this patient we should always do, and which that is look at the nystagmus. If they have nystagmus, there are some clues about it. So they're really straightforward, and again, I apologize for not telling you the number, but it's in there, I promise you. What are the things about nystagmus that are helpful? So what are the characteristics of peripheral nystagmus? That is, I don't have to worry about it. What's the characteristics? It's the key, so first of all, it's unidirectional. So it's not bidirectional. In fact, if you think of your drunk patient, how do they look with their nystagmus? They're going like this. And that is central. Okay, so they're going in one direction. What's really interesting is that it's positional. So when you get them to look in the bad direction, it gets worse. Just like Bppv. So it doesn't change directions. It's one direction, it gets worse. It's also fatigable, just like Bppv. What about central nystagmus? It's bidirectional, and even worse, it changes directions. So they look this way, the fast component's going that way. They look this way, the fast component's going this way. If it changes directions, whoops, that's really bad. If it's downward, and they have the same exact mechanism, a skew deviation, where the 2 eyes are misaligned up and down, you're done. This is an MRI. So there can be clues of that. There's one other thing here, one article, like 7 or 8, I don't remember which one, it's about the Hintz test. And the Hintz test is basically about this head impulse test. There's one article that I know about that claims to have tested this. That's this article. There's a few other articles which say it's a great test, I love it. But there's only one that claims to have tested it. If you actually read this article, didn't really test it at all. But it's on the internet. You can go look on YouTube and see a head impulse test. There's a bunch of videos of it. And I love it because when you look at these videos, they show, okay, here's a normal head impulse test. You turn the head and they look like that. And then here's an abnormal one. You turn the head and you look at them and it's like, what was the difference? I've looked at these videos 50 times. I absolutely cannot tell what they're talking about. They say, look at the eyes, it's doing, I can't even remember what it's doing, but you look at it, it's like, they're identical. It's the same video. What are you talking about? Now there is one video where there's an app on your iPhone where you can record something and then play it back at half the speed, where it slows everything down, where you can actually see it looks different. So I guess you could get this and figure out how to do it. On the other hand, I'm not going to tell you more about it because A, it's untested and unproven. B, it's surely unreliable. That means we would disagree on what we were seeing. C, I don't have the app. And D, if you actually think about what the abnormality is supposed to be, it's sort of like doll's eye, which if you're like me, you can never remember because it's completely counterintuitive. The one that shows you don't have to worry is the one that looks really abnormal. So I don't exactly know how to use it. Anyway, if you want to look this up, you can look it up. I don't think it adds anything. And the good news from my standpoint is I don't need it to be added anything because it's really simple. Figure out what they mean. If we're talking about vertigo, recognize Bppv. If it ain't Bppv, make sure it's not central. And the way you do that is do a good 2-minute neurologic exam. And document your good neurologic exam, and it's done. It's easy. It's really not that hard. And most of them are fine. And when you pick up a subtle cranial nerve abnormality, you feel really good. Questions, comments, thoughts? Go ahead.
Meclizine have any use?
Does which?
Meclizine.
Yes, so Meclizine, so I love it that, so Meclizine is actually has, remember the trade name for Meclizine? Antivert, and I love that because Meclizine is a phenothiazine which is exactly the same as Compazine, except that it has a magic name. Meclizine is for vertigo. We know that because it's not Meclizine, it's Antivert. So whenever you see a name like that, and there's a whole bunch of them in medicine that where they tell you this is not just a phenothiazine, it's a vertigo phenothiazine, it's just marketing. It's pretty amazing. And yet they get away with that. They have, you think of all the benzos which are marketed for different things, or allergy drugs, antihistamines, each of which has a specific use. They're identical. So does it have any use? It has no use for vertigo, but it has use as a soporific. So where you can't do anything else for them, which is the ones who have 2-3 days of, I feel lousy, give them Meclizine, absolutely.